All right, here we go.
Okay.
And we're live in 5,
4,
3,
2.
1.
Hello. Good morning, everyone. My name is Cliff Pierre. I'm a neurosurgery fellow at Swedish Neuroscience Institute, and I'd like to welcome you to our Cerebrovascular Question and Answer Symposium, hosted by the Seattle Science Foundation. It is my distinct pleasure to introduce to you Dr. Shahram Majidi. He's an assistant professor within the Department of Neurosurgery at Icahn School of Medicine at Mount Sinai in New York City. Dr. Majidi earned his medical degree from Tehran University. Then he went on to George Washington University for his neurology residency. After completing training, he then did a clinical fellowship in cerebrovascular disorders at NIH, followed up with endovascular neurosurgery fellowship at Mount Sinai. He stayed on thereafter, where he is now currently one of the neurovascular principal investigators for the COMMAND trial, which is an early feasibility study of the safety of endovascular neuroprosthetic devices and motor control. We're excited for his talk today on endovascular motor neuroprosthesis, the next frontier. And Dr. Majidi, you may share your slides with us, and thank you for being with us today.
Hey, good morning. Thank you for having me. I appreciate the invitation. So I will be talking. Can you see my slides?
Yes.
Yes, we can.
I will be talking about endovascular motor neuroprosthesis, the next frontier, or endovascular brain-computer interface. So these are my disclosures. I will be talking about the device that is not FDA approved and is only authorized to be used within the clinical trials in this talk. So just a brief background. Only in the United States, there are over 5 million people who live with severe paralysis, which could be from stroke, demyelinating disorder, neurodegeneration such as ALS or muscular dystrophy, trauma, or neuromuscular diseases. So if you look at the motor pathway, there are multiple disease processes where the motor cortex, the command center, is still able to fire and generate signal. However, the pathway is severed because of the disease process, such as brainstem stroke, spinal cord injury, Guillain-Barré, muscular dystrophy, or ALS. You see, in all this disease process, patient has lost their motor function. However, the brain cortex, the motor cortex, is still intact and able to generate a unique signal related to specific motor functions. So in some of these diseases, so we might have a solution for that, which is obtaining that unique signals from motor cortex and perhaps decoding them and translating them to motor output. So BCI here has the potential to restore the transmission of neural signal from the cerebral cortex to control digital devices and to improve functional independence in patients with severe paralysis. So the definition of BCI by FDA is implanted BCI devices are neuroprostheses that interface with the nervous system to restore lost motor or sensory capabilities in patients with paralysis or amputation. BCI can be used to replace the lost function, restore it, or even enhance it or supplement it and improve the function. If you look at the history of BCI, the first EEG was recorded by Dr. Berger in 1924, or 100 years ago. But the first time was Dr. Jacques Wedel at UCLA who coined the term BCI with the grant that he had from NSF to study the the brain signals and potentials for BCI. This is the paper from him in 1973, which I wanted to actually highlight this part as he eloquently says that, can this observable electrical brain signals be put to work as carriers of information in man-computer communication, or for the purpose of controlling such external apparatus as the prosthetic devices or spaceship, even on the sole basis of present states of art of computer science and neurophysiology, one may suggest that such a feat is potentially around the corner. And this was 1973. Fast forward, BCI field has developed with some really impressive monumental work by different groups, like this one in 2006 in Nature, when they actually implanted this microelectrode, dural electrode the size of penny in a patient paralyzed from spinal cord injury. And for the first time, they demonstrated that the patient was able to control digital devices such as opening emails or operating TV with just utilizing this microelectrodes placed in the motor cortex. Or in 2013, a group from UPMC, they had a similar approach. They use a 96-channel intracortical penetrating microelectrode in a patient tetraplegic, and the patient was able to operate a robotic prosthetic device, as you see in this video. Very impressive proof of concept, the fact that how we can decode this specific, unique cortical signals and translate them to a motor output. In this segment from CBS. And in 2016, again, similar concept using dural electrode in a patient in a locked-in condition from ALS. They were able to, in fact, create the first example of independent use of intracortical BCI at home. As you see, this was a fully implantable system, needed craniotomy, 16 electrode, 2 bipolar feature channels, and they were able to generate words by average 2 letters per minute after 28 weeks of training. This was the patient's only means of communication. And then lastly, I just wanted again to highlight these are just some great work has been done in this space in the past few decades. And the last one was in a patient with completely paralyzed and lost the speech. Again, they approached the motor cortex with percutaneous implanted electrode array, subdural array through craniotomy with 128 channels, and they were able to generate words and sentences and decode them directly from the cortical activities with over 12 correct words per minute with a significantly reasonable error rate. Again, all these examples are showing that we are able to obtain the brain signal, decode them, and translate them to a motor output, whether operating the digital device or robotic arm. However, if you look at the limitations, such as device longevity and practicality, despite all this amazing work done, BCI has yet to progress to clinical practice. On the right side, you see electron microscopic image of a BCI electrode. Over time, as you see, because of the reaction from the brain and gliosis, there's a missing insulation, there's abnormal growth around the electrode, and separation which essentially cause decrease in the impedance and loss of channel as we progress. All this limitation has prevented BCI to become available in routine clinical work outside the clinical trial. So what option we might have to cross this hurdle? Obviously, scalp electrode or EEGs are not as accurate to obtain reproducible signals from the brain, and invasive electrode has this limitation. But endovascular could be another option to reach the motor cortex or the area of desire without violating the brain anatomy and creating an inflammatory response from the brain. This was developed by Synchron, and as you see, it has three different components. The endovascular BCI by Synchron called Stentrode. It is a 40 millimeter stent with 16 electrode mounted on it. It's connected to a 70 centimeter lead wire, which will be eventually connected to a IRTU, which is implantable transmitter, will be placed under the skin in the chest. And that IRTU will be connected to the external device and eventually to a software computer to decode the signals and translate them to computer output. Again, as you see here, Stentrode is designed to be placed in superior sagittal sinus next to motor cortex through access from jugular vein, and the extension lead wire will come down all the way tunneled into a pocket in the chest and to be connected to a IRTU, which will be connected to external device through Bluetooth. This was developed by my friend and mentor, Dr. Tom Oxley in Australia, with over a decade of work in preclinical and then later clinical work, like identifying this concepts of endovascular electrode in terms of neurostimulation and obtaining reproducible signals in multiple independent publications, as you see here, which eventually enabled them to run the first human clinical trial in Australia called SWITCH trial, which was a Stentrode with thought-controlled digital switch. It was a safety trial, Australian first in human trial to establish the safety of a Stentrode. They implanted 4 patients and they followed them for 12 months for any primary outcome, which was device-related adverse event, and secondary outcome, which was defined as determination of stable signals over time over the course of 12 months of the study, and also functional independence outcome being defined as patient being able to utilize the device independently after a period of training. This is an image from one of their patients in Australia. As you see on the top right side, this is a sagittal view of CT venogram showing superior sagittal sinus, and below is the 3 months after Stentrode has been deployed in superior sagittal sinus, and 12-month follow-up. The same Stentrode is patent with no evidence of thromboembolism or stent migration, any of the cases. This is demonstrating one of their patients. I will let this video run. Utilizing the Stentrode, this patient is able to click by just thinking and turning the light in his bedroom. And these are 2 of the participants in the Australian clinical trial chatting to with each other by utilizing Stentrode along our eye tracking system. It's very unique moment. So eventually they were able to publish their safety result in JAMA Neurology last year. And this enabled us to obtain FDA IDE to start our safety clinical trial in the United States. So we initiated COMMAND trial, which was motor neuroprosthesis to restore motor control for the command of digital device as an early feasibility study, prospective multi-center single-arm open-label study aimed to enroll a total of 6 patients across 3 sites in the United States, including here in Mount Sinai, New York, Buffalo, New York, and UPMC in Pittsburgh. Duration of the study is 15 months per subject to have a full 12 months of follow-up after device implantation. And endpoint was defined as device-related serious adverse event within 12 months post-implant, also target vessel patency and device migration on CT scan at 3 months and 12 months. There was also pre-specified secondary outcome defined as digital device control, patient questionnaire, and caregiver diary. We'll go through the criteria. For COMMAND trial, inclusion criteria includes age 21 to 75-year-old, severe paralysis in both arms and leg. Patient, for the purpose of this early feasibility study, patient should be English-speaking, able and willing to access the study site, and able to provide consent, and patient must have a caregiver who can assist with the study visits and training. As a functional triage test, in order to be eligible for COMMAND trial, when you are holding a smartphone in front of the patient shouldn't be able to touch the screen as a inclusion criteria. They're just to ascertain the level of disability required to be enrolled in this study. So study status, we have completed the enrollment. All 6 patients have been successfully implanted. First US implant of endovascular BCI was here at Mount Sinai in July 2022. A 67-year-old gentleman with complete quadriplegia from ALS. I will go through to his implantation just for the detail of the procedure and planning. So pre-implant planning included obtaining MR venogram. This is just to ascertain patency of cerebral venous system, including patent bilateral transverse sinuses and superior sagittal sinuses. As you see, this patient had dominant right transverse sinus, so we decided to go from right jugular vein into right transverse sinus, then up to superior sagittal sinus. The pre-implant planning also included obtaining structural MRI and functional MRI. The MRI was reviewed to ascertain the intact condition of motor cortex, and also the functional MRI, as you see here on the right side, to make sure the motor cortex is able to fire to commands and is intact. And also the aim of implantation is to deploy the stent rod in superior sagittal sinus at the closest possible location to motor cortex. Stent rod has 40 millimeter total length and 25 millimeter working length. So the aim was to find this area of superior sagittal sinus closest to the motor cortex on the right side, which is which we will mark to have the stent rod to be deployed there. So I have the distal marker, as you see here, this green marker. This is correlating to the anterior border of motor cortex in correlation to superior sagittal sinus in midline. So I have that there. And then M1 marker is 20 millimeter back. And then the proximal marker is 40 millimeter back from the green marker. So I have all these 3 markers bookmarked in my MRI. Then I will transform this MRI and co-register to my angiography during the implantation procedure. And this bookmark and this marker will be used for precise delivery of the stent rod in correlation with motor cortex. So I have that, and this is the day of procedure. Just showing the head of it down here, and then we have two access site. Down here, you see the short 6 French sheet in the left, in the right jugular vein, and up here we have a right radial axis for controlled arterial angiogram. So now we first obtain a baseline arterial angiogram and the 3D subtraction of that, and then that will allow me to transform the previously bookmarked MRI to angiogram. And now you see those 3 markers that I had on MRI being superimposed here to my angiogram, and I can see them and will be used for stent delivery. Now we have the access to the superior sagittal sinus. In this case, we use a 6 French benchmark guide catheter all the way to superior sagittal sinus. And the next step is just to bring the device up there. The stent rod is being provided, preloaded in a 4 French delivery catheter, now being advanced inside the guide catheter all the way to superior sagittal sinus through the access from jugular vein. And here, now you see that in the lateral view of fluoroscopy, I have 3 markers here. I know that the motor cortex is right between this green and yellow markers, and the red will be used to overlay the proximal part of the stent rod right here. So now I'm using these 3 markers and essentially unsheathing my delivery catheter, unsheathing the stent rod. This top marker is the 4 French delivery catheter, my guide 6 French guide catheter down here. Now this is just the maneuver that we need to do to make sure the stent is not going to move forward or backward. Now, after successful deployment of a stent, we obtain a 3D DSA, which is now showing the stent rod up in superior sagittal sinus, and you can actually visualize the lead wire extending all the way from superior sagittal sinus to the transverse sinus and all the way down to jugular vein. This is the 3D reconstruction after a stent rod deployment, as showing that the stent rod is fully expanded and deployed in superior sagittal sinus. As you see, it is connected to a lead wire at its proximal end. So the next step is to now create a tunnel and pocket for IRTU and lead wire. So here you see this is the access site in the right jugular vein. We already removed the sheet. Hemostasis is very easy. It is a vein with 5 minutes of hemostasis that will be achieved. And now I have the lead wire, which is total length of 70 centimeter extending out of IJ. So next step is to create a pocket. You see here, this is our receiver or IRTU. We are trying to create an appropriate size pocket in the right side of the chest. After the pocket has been successfully created and sized, the next step is to create a tunnel to tunnel the wire from neck area down to the pocket. And eventually just place the device inside the pocket and suture the pocket access side. The next step is to plug the lead. Before we suture and close it, we plug the lead into a telemetry unit to ascertain that we are getting signals and device is functional, and also obtain a single shot X-ray to make sure that there's alignment between the lead wire markers and IRTU segments. So we obtained this intraoperative neural data. So now we are ready to close the pocket. And this is the follow-up X-ray obtained after deployment, which is showing stent road and superior sagittal sinus, lead wire extending all the way to transverse sinus and jugular vein, and then tunneled into a pocket in this chest area. All our patients tolerated the procedure very well. They all got discharged home within 48 hours post-procedure. The antiplatelet regimen for our patients in this study was DAPT, aspirin, and Plavix, started 2 weeks prior to implantation, and we obtained the aspirin and Plavix assay 1 week before procedure to ascertain appropriate platelet inhibition. And dual antiplatelet was continued in all our patients for 3 months. At 3-month mark, we obtained a CT venogram. And in all our patients, the CT venogram did not show any thromboembolism. So at that point, we stopped Plavix, and the patient will continue aspirin indefinitely. So right after implantation, usually in a week or two-week mark, the engineers from the study, they go to the patient home and they start the training sessions. So now the patient has fully implanted an internalized device, and then we start training them in doing certain motor attempting to wave hands or tap your finger or tap your foot. Each of this attempt, obviously the patient is completely plegic and unable to generate those movements. However, with each of them, the motor cortex will generate a unique, reproducible motor signal, which will be captured by a stent road and then will be translated to a specific motor output. For instance, tapping your right foot would be right click, or waving will be left click, or tapping your fingers will be enter. So over the course of few weeks of training, the patient will have a dictionary of digital output, which we can utilize by just thinking of a specific motor movement. These are the motor-related cortical potentials that we receive. And this is our second patient here in New York City, which is now using this device to report his pain level to the pain to his caregiver. So he's able to click, select the options. For example, here the pain level. Click 7, and then this is only after a few weeks of training, and pretty impressive that he was able to utilize this after a short period of training. So here, we report a successful implantation of the stent road endovascular brain-computer interface in 6 patients with severe paralysis from ALS or stroke. Stent road has emerged as a leading solution for BCI due to its longevity and simplicity. And minimally invasive endovascular BCI seems to have potential to restore neural signals transmission to control digital devices, and by that, improve patients' level of independence and quality of life with communicating with friends and family and operating digital devices, opening email, doing digital online banking, or surfing on the internet. However, there are significant hurdles which must be crossed before this technology reaches routine clinical use. As you see, when in a neurointerventional space, creating pockets and tunneling and putting a pacemaker-like device in chest is a new territory and chart for us to be. So studies like COMMAND allowing us to understand challenges in this space, such as, for instance, cardiac artifacts and complications related to pocketing and tunneling, or some, although we placing intracranial stenting, whether in a venous side or arterial stenting, has been around for decades. However, leaving a lead wire within the vessel, although in a venous side, is a new concept, and there are a lot of aspects for us to explore and learn in this space. Issues such as stenosis, thrombosis, lead wire induced venous thrombosis, potential infection, hardware failure, lead wire fracture. These are the things that we will learn in the process of this study and future feasibility study. Nevertheless, we can argue that we are at the beginning of new era. I have this quote from one of the very first functional neurosurgery society meeting in 1977, which Dr. Gildenberg says, the design of implantable stimulators has progressed to the point where any desired stimulation can be applied to almost any neural structures. The engineers can give us any stimulation parameters we need. We just have to know what to ask for and where to put the electrode. From there, in 1977, functional neurosurgery has progressed and grown to become a fully, the full field of neurosurgery with some very effective treatment in a wide range of diseases such as movement disorders, epilepsy, eating disorders, depression, etc. So now it looks like we are at the beginning of endovascular functional neurosurgery. We can argue that further technological development will enable us to reach almost any desired location in the brain using minimally invasive endovascular approach. Technologies such as e-shunt, when you think about it, it gives us access to subarachnoid space from superior sagittal sinus. So we can explore plenty of options there in terms of accessing subarachnoid space with a future generation of neuromodulation, neurostimulation, and brain monitoring. And this will enable us to study diseases such as intractable epilepsy, seizure localization, resistant depression, eating disorder, movement disorder. So in the decade to come, endovascular functional neurosurgery perhaps will develop into sizable scale of neuromodulation and stimulation and process evaluation. It's going to be very fascinating to see that and be part of it. And with that, I think that's all I have today, and I thank you for your attention.
Thanks again, Dr. Majidi, for that excellent talk on clinical translation of a new technology, especially within the neuro interventional world, combined with the brain-computer interface. I'm going to open up the floor for questions, see if any of our panelists may have some more attendees, and if not, I'll ask some questions as well.
Sure.
Are you able to hear me there? No, I was sorry. I was struggling with my sound earlier this morning, so I apologize for not being able to speak to you before we started. But congratulations to you and your team. It's wonderful, amazing work, and it does seem almost limitless. I'm wondering, what's the range? Like how far are you affecting the motor cortex? How far does the signal go? How much cortex do you have available to you from the sagittal sinus?
That's a great question. In current version, we want to be as close as possible to the motor cortex in the superior sagittal sinus. We are able to get reproducible signal from legs and arm with attempted movement. Obviously, that's the reach that we have now. There are some preclinical work happening with a next generation of devices that we can go to smaller veins, cortical veins, go right, exit the superior sagittal sinus, go to actual cortex, and be even closer to other areas of interest, such as speech or a little far distant area of motor cortex.
Sorry, I didn't quite understand how getting closer to speech by.
So at the current version of Stentrode that we are working, it's only in superior sagittal sinus. It is able to capture reproducible signal from attempted movement in arms and legs, but cannot reach the speech signal, cannot capture the speech signals and other. But in future, in some clinical work, we are planning to go into the cortical veins and explore more distant areas distant from superior sagittal sinus. Because as you can imagine, in current version, we are limited to areas close to the interhemispheric area within the superior sagittal sinus.
And how much of that device is actual electrode and like the electrical part, and how much that is just the mechanical structure to hold it in place? What I'm really asking is how small can this get? Is it conceivable that you'd put this in arteries?
So the Stentrode has, when it is unconstricted, it opens up to 8 millimeter diameter. And its length, its full length is 40 millimeter. It is similar to stents that we use in arterial side. and it has a total of 16 electrodes mounted over the stent area. In order to go into smaller vessels or arteries, the next generation needs to be much smaller, smaller size. But theoretically, this is doable because the electrode itself is much smaller, and it's mounted over the stent strut.
Right. So this can get very small and go, the lead wire, presumably you could get down to 10,000th or something.
Potentially, it can.
Yeah, that really opens it up. The actual interface, the interface with the computer, that must be an area of incredible opportunity and growth as well. Like when I look at what the patients are doing, it's mostly binary. There's sort of yes, no choices on the computer all the way down. Are there real what are the opportunities as we develop some of the chat GPT type abilities with computers?
Yeah, that's a great question. At this stage, yes, it is really binary and early stage. That's what the stent road is capable to offer at this time. There are some engineering work on other end to further develop that, whether with the more sophisticated computer programs and artificial intelligence. But at this stage, it is that's not available yet. But we have to remember that we are offering this to a very disabled patient, completely disconnected from outside world. For instance, one of the patients that I was counseling and we enrolled, this is an ALS patient. The eye movement machine is now stopping to work. He has no other means of communicating with outside world. One of the main interests that he had, he wanted to be able to control the drone that he had in his backyard, and wanted to just watch the garden with that drone and to be connected to outside world by just moving the drone up, down, left, right. Stent road is able to offer that. Stent road is able to provide this to the patient to communicate with outside. It's very, very early, but monumental for severely disabled patients.
Oh no, I completely understand the life-changing nature of it, and I mean the reality is with binary choices you can communicate anything. It's the speed is all, but you can do anything with it. So I mean the potential is truly unlimited. It's amazing.
Appreciate that.
Yeah, really appreciate you sharing that with us this morning. Any questions from the chat, Cliff, or other questions?
Yep. I don't know if you mentioned this. Is it device MRI compatible at this time?
Well, at this time, based on what FDA regulation, after implantation, patient is not allowed to get MRI.
Okay, got you. With questions from the chat, one wanted to discuss more regarding some of the mechanism of the function of the stent road, and then how connectivity of the motor cortex. Are you doing recordings intraoperatively, EEGs, or everything is done post placement and implanted?
Well, the just pre-op planning is just to obtain a functional MRI, make sure the motor cortex is intact and is generating signal, as I showed on functional MRI. Intraoperatively, I showed in one picture when we connect the lead wire to IRTU, the engineers come into the room, before we suture things inside the pocket, we make sure there is a connectivity and we are getting signals.
Got it. Do you do trial stimulation? Is that part of the trial stimulation phase where you're making sure you're getting signal before you finalize the implantation, or
Yeah,
or-
we just make sure that we are getting some signal, and the system is connected and is operating as a single unit before we complete the implantation.
I think that's most of the questions from the chat. I don't know if any of the other panelists are available. Let me double check here.
If I could just ask one more.
Yes, you can.
Talk a little bit about the trade-off between, the open surgery, the placements, obviously it opens up locations that currently are unavailable to us from the sagittal sinus. How much of a trade-off is that, and how in terms of surface area availability, and we talked about language location. One can imagine, as you said, going through veins with smaller systems, getting to be able to go just about anywhere. Are the open implants going to go away, or what are the trade-offs that, in where that situation where you may still want to do the open placement?
Well, the open placement is really, really amazing with the amount of data that they can get, as I showed in some of the work previously done, generating words like over 12 words per minute is super amazing. However, there are limitations in terms of longevity and the channel persistent over time because of the reaction from the brain, and also invasiveness of the procedure, and the fact that the patient also is going to need to be connected to an external device with a big computer next to him. So those are the issues with open, which I'm sure the technology will further develop in the in following years. We will have a version of open or semi-open BCI. But the beauty of endovascular part, although we are limited in terms of our reach to brain and the amount of signals that we are receiving by only 16 endovascular electrodes. However, animal studies with the stent road has shown that over time, because of endothelialization around the stent road, the signal intensity, in fact, increases compared to with penetrating UTI arrays. Signal intensity, because of the damages, will go down. So these are great opportunities, just showing the potential within the vascular approach. But with further development of next generation of endovascular BCIs and stent road, more electrode or more further, more detailed capture of the signals, I think we have some good chance here for durable BCI options with more longevity.
Yeah. Akshay, you had a hand up?
Yeah, thanks for a great presentation. I really appreciate it. I'm one of the other attendings here, and I wanted to just ask, take a step back, and I honestly haven't done any research on this, but is there been early studies on seizure modulation? Because I can imagine that, cortical irritation depolarization is a common, either problem or something that we can potentially work with, and like a larger population of patients in terms of just what you would capture with a stent road, like people who might have intractable seizure disorder. And I wonder if you can modulate this for that reason.
Exactly. No clinical work there yet, but there are some studies happening on neuromodulation, seizure localization, or even treatment of intractable epilepsy with endovascular approach. I think these are the things that we will be seeing and hearing in the following years to come.
Thank you.
Very exciting. It's such a new frontier.
I had one question in your case series. Are you noticing differences with respect to the intent, like leg first versus, arm? What's the pattern that you're noticing? If you could speak to that.
Well, so we get more higher intensity signals from the legs, but we are able to still obtain reproducible, reliable signal from the upper extremities as well.
Thanks. I think that's most of the questions from the chat. I don't know if there's no further ones, we probably are at time or close to time to ending.
I really appreciate you bringing this to us and sharing it with us. Appreciate your time and appreciate your work, and look forward to seeing it unfold.
Thank you, Dr. McDougall. I appreciate it. It was my pleasure. Thanks for the opportunity.
Take care. Have a great day.
Thank you.
Bye-bye.